Thank you, Professor Petrov. We can continue with our session. Dr. Dimitar Manukov, above and below the knee interventional, complex lesion.
Thank you, colleagues. Thank you. So, dear colleagues and friends, I'm going to share some of our experience about the treatment of peripheral artery disease, and more specifically about the multi-level nature and the treatment of the multi-level extending both above the inflow and below the knee, the outflow. Quickly to the cases. 86 years old female. 6 months prior, she has been performed a PTA of the left P1 with angiolite at extent. Persisting rest pain of the left leg. Quickly to the ABI indexes, we measure it with the blue dot device, very useful. We measure it at the level of the foot, give us information not only about the ABI but also the vascular reserve and the perfusion pressure. So really helpful to identify a critical limb ischemia, for example. Quickly, the access was through the left common femoral artery, antegrade 6 French, under ultrasound guidance, as we do with all our patients. In the middle, you will see the angio of the mid-SFA with one stenosis, and then distally, the transition to the P1, there is the angiolite at extent. On the right, you see magnification of this zone of the popliteal with the angiolite, and just above and below the angiolite, some critical stenosis, and then at the level of P3, some occlusion, with, of course, distal weak collateral filling and slow flow. You will see below the knee occluded anterior tibial artery as well as occluded posterior tibial artery. So we have a really weak flow to the level of the foot. You will see just the slow flow and probably some dominant peroneal artery that is supplying the common plantar and the lateral plantar artery. So what we did next was some quick balloon dilatation with a Pollock semi-compliant 2-0 balloon. The idea was just to be able to pass the IVUS probe so we can perform an IVUS of this whole femoral popliteal zone. The idea was to, of course, avoid any complication in this flexion zone and to improve, of course, the result in the patient, of course, to avoid the implantation of stent at this place. So starting the IVUS run from the distal P3, this is, you see on the right, a relatively healthy segment. And now coming to the proximal, we will see just where the occlusion was. This is the place. After that, we're going back, and you will see one relatively healthy segment at the level of the P2 right here. And then going back, we will reach the stenosis just distal to the stent. Again, a massive plaque there, as you see here, and on the IVUS run. And then we're going to the stent that was implanted, and we'll see the malposition of the stent. You will see it now on the IVUS run. The stent, however, without any restenosis, so this was good. And after that, just proximal to the stent, the segment, again with diffusely diseased here segment, again massive plaque, and finally a relatively healthy segment right here at the end. So the idea was to perform IVUS and actually to reduce the binary restenosis, as several studies have shown, reduce the binary restenosis by more than 20%, especially in people treated with drug-coated balloons. And this is exactly what we did in the patient. We performed some balloon dilatation with a 3-0 balloon, 4-0 balloon, just distal and proximal to the stent. And after that, with some prolonged inflations, we performed PTA with drug-coated balloons. Again, 3-0, 4-0, and 5-0 with about 2 minutes of inflation, as we usually do. What we had was some mild dissection just proximal to the stent, but without flow limitation. We had some improvement, of course, of the outflow. We can better see the tibial vessels now. We saw the occlusion of the anterior and the peroneal. So while we were waiting to see if there's going to be any acute recoil in the treated segment, we went on and decided to try to recanalize the anterior tibial artery with the support of the Oscar 2.5 catheter. We passed the occlusion. We performed dilatation of the anterior tibial and the peroneal artery as well. After that, we went through the pedal loop, as you see in the middle, performed PTA with the Paseo 2.0 balloon. We even tried retrogradely from the pedal loop to go into the tibial, posterior tibial artery. We couldn't manage. We tried even from antegrade, but because the distal part of the posterior tibial was with bends and calcification, we couldn't pass this place. Anyway, after that, we checked the dissection. It was persisting again without flow limitation, but we decided to be secure about this place and implant one pulsar stent 560 just to be sure we didn't ruin the whole work that we've put so far in this patient. And finally, this is the final result we have in all the segments that we treated, starting from the left, the femoral artery, the P1 segment, as you see. In the middle, the tibioperoneal trunk and the tibial vessels. We even have some flow in the posterior tibial to the place where we were able to reach. And finally, we see the vessels at the level of the foot. So I think pretty good result, having in mind what we had. The next patient, 51-year-old male, post-amputation of left leg at the level of the thigh, now with ulcers at the level of the Achilles tendon of the right leg, with muscle contracture because he used to keep his leg in external rotation. This was the main problem in the beginning because he couldn't get his leg straight until the mild sedation kicked in. This is why the images are a little bit blurry, but you can appreciate the diffusely diseased SFA, the occlusion in the mid-SFA. Then you will see on the right the collateral filling of the popliteal artery at the level of P2, let's say. And below the knee, you will see occlusion at the level of P3 with occlusion of posterior tibial, just one patent anterior tibial artery, and of course very weak flow on the right to the level of the foot, you will see. So what we tried was antegrade with an Oscar 4 French. We couldn't cross from antegrade the occluded segments, so we switched to a retrograde through the distal anterior tibial artery. We use Terumo Advantage Track 014 and the support of a Navi Cross. We managed, initially we went into the posterior tibial, as you see on the left. We redirect, we pass the whole occlusion, and on the right you will see the externalization of the wire through the sheath. After that, pretty easily with the Oscar balloon 4x200 PTA, starting from the P3 proximal to the proximal part of the SFA. We perform dilatation. On the right, you will see now the better and of course improved inflow. We can better appreciate the anatomy now below the knee. On the left, you will see the puncture site of the anterior tibial and the torquer of the wire. So what we did next was we switched the wire, and from retrograde we switched it to antegrade. As you see in the middle, we passed the pedal loop and we went into the posterior tibial artery. We sealed the puncture site with the 3.0 balloon. By this we performed PTA and of course of the anterior tibial. With the support of the balloon, we pass the whole posterior tibial, as you see on the right, and we perform PTA of the whole posterior tibial, the pedal loop as you see now, and the dorsalis pedis again. After that, going back to the SFA, because there was some long occlusion, expectfully, we performed a PTA with a drug coating balloon, the Luminor 5200 and Paseo Lux 5x120. You see we started from about the level of the P2 and going to the proximal superficial femoral artery, and still the dissection was persisting at the mid to distal SFA and going into the P1. So this dissection we had to cover with the Pulsar self-expandable 6x200 stent. And these are the final images on the left with the improved, expectfully improved anchiobrachial indexes on the next day After the procedure, you see the inflow to the posterior tibial, and finally you will see the vessels at the level of the foot with a pretty good result, I think, in this patient. And finally, very quickly, the last patient, 74-year-old male with resting pain of the plantar part of the foot. In the first procedure, we performed PTA of the mid-SFA. He had an occlusion, including we had to perform a retrograde puncture through the popliteal. Anyway, we recognize it. The patient has some declined kidney disease, so we left the below-the-knee interventions for a second stage, and this is what we did exactly. On the left, you will see the posterior tibial artery with the occlusion of the peroneal and tight stenosis at the distal anterior tibial artery. Then on the right and in the middle, you will see the vessels at the level of the foot with, I think, a major and the dominant artery that supplied the posterior tibial, no like dominant dorsalis pedis, so we decided to attack the posterior tibial artery with the Oscar balloon, with the Oscar device 2.5. We tried from antegrade, we couldn't pass. You see a lot of calcification in the vessel wall. We couldn't pass, so we switched to the retrograde access through the common plantar with the Terumo Advantage 014 track and the Navicross. We managed to puncture and to went retrograde and to pass the occluded segment, and we end up into the support catheter, the Oscar catheter, as you see on the left. With the Navicross and the wire, we enter the Oscar support catheter. After that, we just pull the wire and advance it from above, as you see in the middle. We managed to get it straight into the Navicross, as you see in the middle, and we externalize it, and by this, we continue in a antegrade fashion. The PTA on the right is with the Oscar balloon 2.5 very easily. And after that, of course, we wanted to continue, so we continue with the Oscar balloon. We passed the puncture site, as you will see on the left. We went into the lateral plantar artery, finally. And we wanted to go into the deep plantar artery to perform PTA. So this is what we tried to do. In the middle, you see the now segment of the PT, posterior tibial, with a good flow, and you see the flow reaching to the middle of the lateral plantar. On the right, you see the Oscar balloon, just the distal marker where it is. You see some massive calcification and probably dissection there. We couldn't pass this spot, even with a coronary 1.0 balloon, probably because there wasn't enough wire length distally to pass the balloon. So what we did was we punctured the first metatarsal artery, as you see on the left, and through the needle we externalized the wire, and by this we could push the whole system, the wire with the pre-mounted balloon on it, and by this reaching finally the distal lateral plantar artery. And as you see on the right, this is exactly the moment when we are pulling the wire with the balloon mounted on it. After that, we made a quick PTA with Paseo 2.0 and NC Achilles balloon to 22 atmospheres in this place. And this is the final result that we had. In conclusion, we can say that these multi-level disease segments can be treated. Yeah, it takes time, takes different devices, different puncture sites, but it can be, it's possible, it's feasible to be performed. Sometimes it is good to be and happen in one procedure. Sometimes it needs to be done in a staged manner, depending on the patient and the anatomy. Thank you very much.
Thank you. Very good case presentation. Any question, discussion, suggestions? Professor Petrov.
Congratulations. In fact, it's quite important to know that we have a new guideline of European Society of Cardiology for peripheral arterial disease. And this is the first complex peripheral arterial and aortic disease guideline of the European Society of Cardiology. It's a huge guideline treating the questions about from head to toe. And this is really great. And in this guideline is, in fact, they are advocating the strategy that Dr. Manukov has shown very well. So in the previous time, you know very well, all of us, we know very well, that there was a trend just to touch the proximal lesion and to go home, so to leave the patient behind. And because of that, in the past, we had a huge amount of restenosis and mainly rethrombosis because the runoff was not provided. And what has shown, in fact, in the majority of the cases, especially in critical limb ischemia, we have to perform with all the possibilities that obviously we have. Retrograde approach through the loop, through the collaterals, antegrade, retrograde, brachial approach, radial approach, tibial approach, and so on. But all these armamentarium, microcatheters, draculutin balloons, everything is, in fact, is intended to improve the flow of the artery. And if two arteries going to the foot, better. So I have shown yesterday by the thermography that we are utilizing, it's like a perfusion showing technique, that it's better to improve, especially in patients with wounds. It's definitely the congratulations for the cases. They are really very thoroughly, very well done, and this is the right behavior.
Thank you.
Thank you.
Professor Petrov, about the peripheral and the CTO, I mean, perfect approaches, perfect puncturing, you're finishing the perfect result. About the peripheral CTOs, below the knee especially, do you have, we have some theory that I started in my cath lab. Every patient with a severe symptomatic peripheral artery disease, either with occluded stents, occluded bypass grafts, CTO natives, do you follow the superficial veins? Because superficial veins, in our theory that we started 2 years ago, it's compressing or making a higher pressure on the capillary level and not allowing the arterial blood to go easily to the vessels and to the cells. So in every patient with a peripheral artery disease, we are measuring the safena magna incompetence. Is it a low level, high level of incompetence of the veins? And we managed 150 patients doing just sclerosation or deactivating the safena magna to get better inflow of the arterial or collaterals of the below the knee. Even making a parallel comparison, ergo test before and 2 hours after the sclerosation. They doubled the walking distance. Even the PSV of the peripheral of the tibial arteries are higher than before the sclerosation. So this is just our theory that we started 2 years ago, and my PhD actually is correlated with this. And up to now, we have a very good results.
It sounds very interesting. It sounds very interesting. In case you prove it, it will go to the guidelines.
Thank you, Dr. Manukov.
Thank you.